Welcome back to the deep dive. Okay, we know your time is valuable, so we've looked at all the source material you sent on cell pathology. Our mission today, really cut through the noise.
Yeah, get straight to the point.
Exactly. We're diving into irreversible cell injury and specifically the really visually striking world of necrosis.
Right. Necrosis, uncontrolled cell death. It's messy, it's inflammatory. But the key thing for pathology really is understanding why it looks so different depending on where it happens. Why a heart attack, leaves the tissue firm and pale, but a big stroke. It just turns the brain into, well, a liquid mess. That's what we want to decode today. The 6 main types and the kind of buzzwords that help you recognize them.
And that difference, firm versus liquid, that feels like the absolute core distinction we need to grasp first.
Yeah.
Right? We're talking cell injury, irreversible injury,
Yeah.
necrosis. So before we get into all 6 types, let's just anchor on that central question.
Absolutely. It really boils down to a biochemical race. 2 main things happening in that dying cell. On one side, you've got protein denaturation. Think of it like cooking an egg white. The proteins tangle up, solidify, lock down.
Right, structure forming.
Exactly. On the other side, you have enzymatic digestion. This is where the cell's own digestive enzymes, or maybe enzymes from inflammatory cells, are released and just start, dismantling everything, liquefying it.
Okay, so it's a race between locking down and dissolving.
Precisely. And whoever wins that race determines if the dead tissue basically keeps its shape or just turns into mush.
And for most of the body, the solid organs anyway, when you cut off the blood supply,
Right.
it usually goes for the lockdown, right? The firm option.
That's right. Which brings us straight to coagulative necrosis. This is kind of the default mode for ischemic death, lack of blood flow, usually an artery getting blocked. It's the signature look in solid organs with those single and arterial supplies. Think heart, kidney, spleen. In that ischemic environment, protein denaturation just wins out overwhelmingly.
So that's the firm death. And it's weird because the overall shape of the tissue can stay intact for a bit, can't it? Even though the cells are dead inside.
That's the really key feature. The basic architecture, the sort of scaffolding of the cells and the connective tissue, it holds up temporarily.
Why?
Well, because the enzymes that would normally chew it all up, they get denatured too by the low pH, the acidosis that comes with ischemia. So microscopically, you see these ghost cells.
Ghost cells, okay.
Yeah, you can still make out the cell outlines, but the nucleus, gone. Poof. And the cytoplasm is super pink eosinophilic because it's packed with all those denatured proteins.
Right, right. And that firmness, that density explains why heart attacks, for instance, cause those pale or anemic infarcts, doesn't it?
Exactly. The tissue's so dense, when the blood stops, there's just no room for blood to seep back in and make it look hemorrhagic or red. It stays pale.
Okay, so coagulative is the rule for ischemia in most solid places.
But there's always a but in biology, isn't there?
Huh. Seems like it.
The brain. The brain is the huge exception everyone needs to nail down. It does not coagulate when ischemic, it liquefies.
Okay, let's flip that coin then. Liquefacted necrosis.
Yeah.
The liquid death. Here, the enzymes win, hands down. Total destruction. Why the brain? Why does it melt?
It's all about what the brain is made of. Unlike the heart or kidney, it has very little tough structural connective tissue, collagen and stuff. There's no rigid framework holding things together.
Okay, less scaffolding.
Right. Plus, it's loaded with lipids, all that fatty myelin sheathing the nerves. And crucially, it has its own little cleanup crew ready to go. The microglial cells.
The brain's immune cells.
Exactly. So when ischemia hits the brain, these microglia just go wild. They release a massive flood of hydrolytic enzymes. And because there's not much protein structure to resist, and you've got this enzyme tsunami, the dead tissue just gets rapidly digested into, well, a liquid-filled cyst almost right away.
So a stroke literally creates a pocket of liquid.
That's basically a liquid mess where brain tissue used to be.
That makes sense. So liquefactive necrosis, whether it's the brain's own enzymes or enzymes from somewhere else, it always comes down to having lots of active enzymes doing the digesting.
Perfect summary. Think about the other main place you see liquefaction. An abscess.
Like from a bacterial infection.
Right. In an abscess, the enzymes aren't mainly from microglia. They're from the huge army of neutrophils that rush in to fight the bacteria. These neutrophils are packed with powerful lysosomal enzymes. They release them, digest the tissue, digest the bacteria, digest themselves, and create pus.
So pus is essentially liquefied tissue and dead cells.
And dead neutrophils, yeah. It's enzymatic destruction. Either way, brain's own cells or incoming inflammatory cells.
Okay, that gives us a really solid foundation. Firming up, coagulative, versus melting down. Now we need to layer on the other 4 types, which are kind of variations on these themes, right? Based
Yeah.
on specific causes or locations.
Exactly. They often involve one of these core processes but have a unique trigger or appearance.
Let's start with the one that sounds kind of gross, the cheese death.
Ugh. Caseous necrosis, yes, cheese-like. It really does look like it.
And this is the big one for TB, tuberculosis.
Absolutely. TB is the classic cause, but you can also see it in some systemic fungal infections like histoplasma.
Hmm.
Grossly, yeah, it's white, soft, crumbly, like cottage cheese, basically.
Not something you want to see. What about under the microscope?
Histologically, it's super important because it happens inside a specific immune structure, the granuloma.
Right, the body trying to wall off the infection.
Exactly. So in the middle of this granuloma, you see this pink, amorphous, structureless debris. That's the caseous necrosis. And it's surrounded by specialized macrophages called epithelioid cells and sometimes giant cells, the immune system trying to contain the cheesy mess.
Okay, and this is a key point, isn't it? Because not all granulomas have this cheesy center.
Correct. And that's a crucial distinction. If you see a granuloma with that central amorphous caseous necrosis, you should be thinking case-eating granuloma. And your top suspects are infections, TB, fungi.
Got it. Infection, case eating.
But if you see a collection of those epithelioid macrophages forming a granuloma without the central necrosis, that's non-caseating. And that points more towards inflammatory or autoimmune conditions, things like sarcoidosis or Crohn's
It's
disease.
super helpful rule of thumb.
Yeah.
Okay, from cheese to chalk. Fat necrosis.
Right, the chalky death. This is where biochemistry gets weird in the body. You literally make soap.
Soap. How?
It happens typically around the pancreas, especially in acute pancreatitis when the pancreas gets damaged and leaks digestive enzymes, or sometimes after trauma, like to the breast tissue. The key enzyme is lipase.
Okay, lipase breaks down fat.
Exactly. It breaks down triglycerides in fat cells, releasing free fatty acids. And here's the cool, gross part. These fatty acids then chemically react with calcium ions floating around in the tissue fluid.
And that makes
Those
sense.
calcium soaps. It's a process called saponification. These form little chalky white deposits that you can actually see grossly.
Wow, so that's why it looks chalky white.
Yeah.
And microscopically.
You see the outline, sort of shadowy ghosts of the fat cells, but they're often filled with or surrounded by these granular basophilic bluish deposits. That's the calcium binding to the fatty acids.
Okay, fascinating. Next up, fibrinoid necrosis. This one sounds different, more about blood vessels.
Yeah, fibrinoid necrosis isn't about a whole chunk of organ dying. It's specifically damage within the wall of a blood vessel, the pink vessel death.
And you see this when vessels are under extreme stress.
Exactly. Think severe high blood pressure, like malignant hypertension or immune attacks on the vessel wall, like in vasculitis or even in preeclampsia. The lining of the vessel, the endothelium, gets really badly damaged.
Okay, so the wall breaks down.
Kind of.
Yeah.
Plasma proteins, especially fibrin, leak out of the bloodstream and get deposited right into the vessel wall, along with immune complex debris sometimes. On the standard H&E stain, this mixture looks bright pink or eosinophilic and kind of smudgy.
Ah, so fibrinoid because it looks like fibrin and it's pink.
That's the idea. It's basically proteinaceous junk plugging up a damaged vessel wall.
Got it. Okay, last one on our specific list. Gangrenous necrosis. This always sounds particularly bad.
It often is clinically, but pathologically, it's more of a pattern applied to limb or bowel ischemia rather than a totally unique cellular mechanism. We split it in two.
Dry versus wet.
Right. Dry gangrene is basically just coagulative necrosis happening in a limb, usually due to slow chronic arterial blockage, like in peripheral artery disease or diabetes.
So the tissue is dead, firm, black, shriveled.
Mummified, yeah. It's dry because there's no significant infection, just ischemia leading to coagulation. But
Oh, here comes the butt.
if you get a significant bacterial infection on top of that dead ischemic tissue, now you've got wet gangrene.
So the bacteria add another layer.
They add a liquefactive layer. The bacteria attract loads of neutrophils, remember?
Yeah, releasing enzymes.
Exactly. So wet gangrene is this nasty combination of underlying coagulative necrosis from the ischemia plus a superimposed liquefactive necrosis from the bacterial infection and inflammation. That's why it's swollen, soft, maybe bubbly from gas produced by bacteria, and smells awful.
Okay, that really clarifies it. Wet gangrene is basically coagulative plus liquefactive, a double whammy.
Precisely.
Okay, so we've got our 6 types. Now let's zoom out a bit. How do these fit into bigger clinical pictures? We touched on infarct colors, pale versus red.
Yeah, that's a really important distinction. We said pale or anemic infarcts happen with arterial blockages in solid organs like the heart or kidney, leading to coagulative necrosis, and the tissue's too dense for blood to seep in.
So red infarcts are the opposite. Blood does get in.
Right. Red or hemorrhagic infarcts happen when blood can pool in the dead area. This occurs in a few scenarios. In loose tissues like the lungs, where there's space for blood to extravasate. Or in organs with a dual blood supply, like the liver or the intestines. If one supply is blocked, the other might still allow some blood in. Or if blood flow returns after the tissue has died, reperfusion, it can bleed into the damaged area. Also, if the venous outflow is blocked, blood backs up and hemorrhages into the tissue.
So loose tissue, dual supply, reperfusion, or venous blockage can all lead to a red appearance.
Exactly. The key is blood getting into the necrotic zone.
Now, something else really critical when we talk about ischemia is that not all tissues are equally vulnerable, especially to just low blood pressure overall, right? Like in shock.
Absolutely critical point. We need to talk about watershed zones.
The border territories.
Yeah, think of them as the areas furthest away from the main arterial city centers. They sit right on the edge, the border between the territories supplied by two different major arteries.
Farthest from the source.
Precisely. So if the overall systemic blood pressure drops significantly, like in shock, these areas are the first to lose perfusion. They don't get enough blood flow because they're at the very end of the supply line.
And there are some classic watershed zones we need to know.
Definitely. The source material flags a few high-yield ones. In the brain, a key watershed is at the junction between the territories of the anterior and middle cerebral arteries, ACA-MCA border.
And infarcting that
Can
causes.
cause that man-in-the-barrel syndrome. Weakness in the shoulders and upper arms because that brain area controls those regions. But the hands and legs might be okay because they're supplied more centrally. Really specific deficit from a watershed infarct.
Wow. Okay, where else?
In the colon, the classic watershed is the splenic flexure. It sits right between the territory of the superior mesenteric artery, SMA, and the inferior mesenteric artery, IMA, prone to ischemia during shock.
Makes sense. Heart.
In the heart, it's the subendocardium. That innermost layer of the ventricle wall is furthest from the coronary arteries on the surface, so it suffers first with generalized low perfusion.
And the liver.
The liver has its zone 3, the central lobular area, right around the central vein. This area gets the blood last, so it has the lowest oxygen. Plus, it's packed with CYP450 enzymes for detoxification.
Ah, so it's vulnerable to both low oxygen and certain toxins.
Double hit potential, exactly. Acetaminophen overdose, for example, preferentially damages zone 3 because the toxic metabolite is generated there by the CYP450 enzymes.
Okay, really important concept, those watershed zones. One last clarification point before we wrap. Calcium. It pops up in two types of necrosis we discussed.
Right. We need to clearly separate them. We had saponification in fat necrosis.
Which was active enzymatic lipase making fatty acids that bind calcium, making soap.
Correct. Active process involves lipase, makes chalky deposits specifically in fat, and importantly, the patient's overall blood calcium level is normal.
Okay, what's the other way calcium shows up?
That's dystrophic calcification. This is completely different. It's a passive process. Calcium just sort of precipitates out of the tissue fluid and deposits onto any kind of dead or dying tissue. Doesn't have to be fat, doesn't involve lipase.
So it's like calcium building up on wreckage.
That's a great analogy. Think of old scar tissue from a heart attack or damaged stiff heart valves. They often become calcified over time. That's dystrophic calcification. And again, the patient's serum calcium is typically normal. It's a local problem in damaged tissue.
Okay, crucial difference. Saponification is enzymatic soap making in fat. Dystrophic is passive calcium deposition on any old damage.
You got it.
So, wrapping this all up for you, the listener,
Yeah.
what's the big takeaway? It really seems to circle back to that initial race, doesn't it? Irreversible cell death looks different, mainly because of whether proteins just lock down and coagulate, or whether enzymes win out and liquefy everything.
That's the absolute core concept. Coagulative versus liquefactive. Everything else, the cheese of TB, the chalk of pancreatitis, the wet versus dry gangrene, it's all downstream of that. Influenced by the specific tissue, the cause, maybe infection.
Understanding that core battle really helps make sense of the diversity.
It does.
Yeah.
And that brings us to a final thought, kind of linking back to that calcium idea. We just talked about dystrophic calcification, passive calcium buildup on old damage, like scars or bad valves. Now imagine that same passive process happening, but on a microscopic scale inside certain types of tumors. You get these tiny layered onion skin-like calcium deposits that pathologists actually use to help make a diagnosis.
Ah, okay. Microscopic dystrophic calcification in tumors.
What are those little calcified bodies called, and what's a classic tumor type where you'd look for them?
You're talking about psammoma bodies, aren't you? Those
Like,
laminated calcification.
exactly, psammoma bodies. They're a perfect example of dystrophic calcification, just tiny ones. And you classically see them in things like papillary thyroid carcinoma, also some ovarian tumors, meningiomas.
So the same basic principle of calcium depositing on damaged or abnormal tissue applies even down to the microscopic level in cancer.
Precisely. It just shows how these fundamental cell injury processes echo through all sorts of pathology.
That's a fantastic connection to end on. Thanks for walking us through the often confusing but visually fascinating world of necrosis.
My pleasure. It's all about recognizing the patterns. Thanks for digging into this source material with me.